Hi everyone, in this video I'll be discussing hormonal agents. So some of the hormonal agents are used in the treatment of cancer because we know that there are certain cancers like prostate cancer, breast cancer, they depend on hormones for their proliferation. Now in a hormonal agent, the first one I just want to tell you is corticosteroids. Corticosteroids, what do they do? They decrease the T cells more than they decrease the B cells. Now, we want to do that. Where to use these steroids? They are used in two important conditions. One is leukemia, and one more condition is called lymphoma. So, in those conditions, steroids can decrease the T cells and they can decrease the B cells. And we have discussed the regimens also in lymphomas. Now, apart from this, what are the common use preparations of steroids? Preparation of steroid used as anti-cancer drugs. One is prednisolone, and one more, the dexamethasone. Dexamethasone. Now, what is the advantage of steroids in cancers? What do they do in cancer patient? Cancer patients, what is the advantage? The advantage is when we are using them in cancer patient, they have antiemetic effect. And we have discussed that in CANV, we use dexamethasone to suppress the vomiting. And also they have mood elevating property, which is very good because most of the cancer patients are depressed and these steroids will elevate the mood. And importantly, they can also be used to manage hypercalcemia. So these can also manage hypercalcemia. So they can decrease the calcium levels also, and they can also decrease the cerebral edema. So the advantage of this steroids are they can decrease the hypercalcemia, which is seen in malignancies, and many times malignancies will be associated with inflammation and edema. So in that cerebral edema, that steroids will decrease it, and the drug which is used in cerebral edema is dexamethasone. So this is the advantages of steroids in cancer patients. Then let us discuss what about the drugs for prostate cancer. So what are the options we have? Hormonal agent to treat prostate cancer. So number one, we can use androgen receptor antagonist. Androgen receptor antagonist. Now these drugs end with flutamide. Example is flutamide. So they end with flutamide, then nilutamide, then bicalutamide. So anything ending with lutamide, they are androgen receptor antagonists. That can be used. Second option what we have is we can use GnRH agonist. So when you are using GnRH agonist, they should be used continuously. So they are not used intermittently, they are used continuously to decrease the testosterone secretion. Now another important aspect what we can do is we can use GnRH antagonist. GnRH antagonist, and they also decrease the release of testosterone, and the name is abarelix and degarelix. So these are GnRH antagonists that can be used. Now in older days, the estrogen preparations were used in prostate cancer because estrogen was thought to decrease the secretion of pituitary hormone, that is LH and FSH, because of negative feedback. So estrogen was producing negative feedback on FSH and LH, decrease the release of FSH and decrease the synthesis of testosterone. So keeping that in the mind, estrogens were also used in prostate cancer, not now, earlier days. And the estrogen preparations are estramostin. I told you it is a combination of estrogen and normostin, and a drug called fosfestrol, which is converted in the prostate into stilbestrol. So these are the drugs for prostate cancer. Recently, we have one more drug that is used for prostate cancer, which inhibits the androgen synthesis. It's a 17 alpha hydroxylase inhibitor. And the name of that drug is called abiraterone. It is called as abiraterone. So these are the drugs what we use for managing prostate cancer, and these are all hormonal therapies for us. Now moving on to another important cancer, and that is called the breast cancer. So what are the important drugs you have to keep in your mind when you are managing the breast cancer? Hormonal agents. Now the breast cancer may be in the premenopausal woman, or it may be seen in post-menopausal women. For breast cancer, we have plenty of therapies. In that, hormonal agents is also one. So for both pre and post-menopausal women, the initial therapy will be with the serum, and the serums what we use are tamoxifen, or there is one more drug, tormefen. These are the serums which can be used for that. In postmenopausal women, if the tamoxifen is not working, tamoxifen resistant cases, then we move to the next category of drug. They are called as aromatase inhibitors. Aromatase inhibitors. In that we have two categories. The irreversible blockers. They are irreversible blockers. And one more category is reversible blockers. In irreversible blockers, we have a drug which ends with mestane, hexamestane, and 4-mestane. And in reversible, we have the drugs ending with ozone, letrozole, anastrozole. So remember, these drugs end with ozone, and these are used for only post-menopausal breast cancer, not for premenopausal. So post-menopausal tamoxifen resistant cases, we give aromatase inhibitor. Still the patient is not responding. There is aromatase resistant cases. Aromatase inhibitor resistant breast cancer. Then the next modality of treatment will be from a drug by the name SERDs. SERD stands for selective estrogen receptor downregulator, and the drug name is called fulvestrant. You read the name, it is a full estrogen receptor antagonist. It's a full estrogen antagonist. The name is fulvestrant. So this is a flowchart of hormonal therapy. SERM, which is used for both pre and post-menopausal. Post-menopausal tamoxifen resistant, we go for aromatase inhibitors. If it is resistant, then we go to the last resort, that is fulvestrant. So that is in brief the hormones used in cancer chemotherapy. Thank you all.